see it if that's possible, and they want to be involved, because they do get a sense about what's happening. And as soon as the family saw what was happening, as soon as the father got there, they both wanted to stop, and that was the right thing to do. But also the right thing to do was to keep going until they could get there. The other thing is make sure your team's on board with stopping. So you, as a team leader, you want to ask your team, is there anything that we are forgetting? Is there anything we haven't done? Have we made sure our compressions are right? Have we given bicarbonate calcium if it's a dialysis patient? Have we checked sugar, whatever good that may be? So it doesn't matter. So everybody on that team needs to be involved in that decision making. If somebody thinks that there's something else that can be done, then you ought to respect that for the team member and at least give it an effort. So I always poll everybody in the room. Does anybody have any other suggestions? Does anybody have any objections from us stopping this code? And we don't stop until everybody is on board with stopping. So let's get through the phase 4. So phase 4, we're really now at the 30-minute mark. There's been no response. So we know the prognosis now is grim. It's a 0% chance of survival here. The family, hopefully by now, understands that because we've explained this to them now over 3 different sections. So I'm going to skip through this to the get and give. So here you can say, unfortunately, Mr. Smith is just not responding to our efforts. If we've been talking over the last 30 minutes or so, we've done everything that's possible to do for Mr. Smith. Everything that can be done for him in the hospital has been done for him right here in the living room. And unfortunately, he's just not responding to our efforts. So at this point, our team has discussed this, and our team is in agreement. No one has any other suggestions. We don't feel like there's anything else we can do to increase his chances of survival. We'd like your permission to stop. And I think that's important to ask the family to give you that permission. If they say no, then that's okay. Say, we're going to go another 5 minutes, and then if there's no response in 5 minutes, then we're going to stop the resuscitation. Because sometimes I think it's important to get the family involved in the decision making and let them be part of it. But remember, family members don't always want to be the one that says stop, because they want to do everything possible to keep their loved one alive. And the reason I put it that way is because you really don't know until that question gets asked what kind of family you're dealing with. So some family members or some families they're very comfortable in making that decision if they want to stop. They've witnessed this resuscitation. They've seen how violent it is. They've seen how hard everyone's worked, and they're ready to stop this resuscitation. But remember, some family members don't want to be that person to say, yes, stop. And I think it's important that we don't force them to be that, because that's something they're going to regret for the rest of their life. So that's a way to give them the out and say, that's fine. We will continue for another 5 minutes, but at that point, if he doesn't have any response, then we'll need to stop. And you can say it just like that. So that way you've given them an out, because sometimes they understand that their family member is not going to survive. They just don't want to be the one that says no or pull the plug. All right. So again, let them to react to the information you've given. Let them have silence. If we're going back to the resuscitation, let them go back to the resuscitation. But if we've stopped, then I think it's important to let them go back and see their loved one. Now, I'm going to skip through just a little bit here to the end. So, let's say now we're at the 30-minute mark and we've stopped this resuscitation. So what I would do as a team leader is to make sure that you kind of tidied up the scene. You've removed all the Bristajet caps and IV bags and everything else and kind of cleaned up the room before you let the family member go back in. Now, obviously, if it's a medical examiner's case, then it's different. You've got to handle that differently. Obviously, you're not going to let anybody disturb the body or potentially tamper with evidence. So, and you've got to explain that to the family. That's in any case why you can go back in the room. We can't let you touch the body. We can't really remove anything at this point. But if it's not an ME case, which most cardiac arrests at home are not, then there's some things you can do to make it a little easier for the family. One, I'd say clean up our mess, clean up the mess we've generated with this cardiac arrest. The other thing you can do, if somebody's on the floor, you can actually put them on a sofa or put them back in bed, because most folks, most adults don't lay in their floor anymore, so it's kind of an unnatural position to be in. So as long as it's not an ME case, just ask the family, can we put Mr. Smith on the sofa? Can we put him in the bed? Make sure that you're treating that body with the utmost respect. And if you can, try to elevate the head, 10 or 15 degrees. That just prevents lividity. The face can turn kind of purple after death and become discolored. So if you just elevate the head a few degrees, that prevents the head from turning that bluish discoloration. one of the things when I was kind of putting this course together and reading a lot of literature, reading responses to families and some of the interactions they had in the hospital and pre-hospital, one of the things kind of stood out to me. There was a daughter that was talking about she witnessed the resuscitation of her father, and she said, the pre-hospital folks were great. They did a great job. They were very attentive and caring to her. She said the only thing that really troubled her was after it was all over, that folks continued to step over her dad's body. So they were cleaning up stuff around the scene. They were trying to do what was right, but folks were stepping over the body. And that's something she's going to remember for the rest of her life. So just remember, you treat the body with the utmost respect and treat them just as if they were alive. And allow that family to go back and touch and stay with that loved one as long as they want, or until you've been able to make arrangements for disposition of the body, assuming it's not an imminent case. So now after this is all over, it's really time to make sure you get some support for the family. So if there's a chaplain you can call them. If there's neighbors or family, anyone, try to make phone calls to get support folks for those family. And try not to leave the family alone. You want to release all your other responders when this is over, but you don't want to leave family members completely alone after this has happened. Some instances folks want to be left alone, and so I think that's fine. If they are adamant that they want to be left alone to maybe a funeral home or however you dispo bodies, however that process takes place here. So make sure that if there's anything you can do for that family, you do for them, because that just imparts a really caring attitude. And obviously you've got to follow your protocols here. So death certificates and things like that are going to have to be arranged, and that really depends on your local protocols here. We'll skip through that. So now let's get to the things not to say. So there are a lot of things that we shouldn't say. And I'm going to show you a lot of stuff that has been said. Several studies have been done where they film nurses and physicians interacting with family members during a resuscitation or immediately following the resuscitation. So everything that I've got on these screens is something that was actually said by a healthcare provider. Most folks aren't going to say these, but there are some pretty bad examples of things not to say. So religion is probably one of the things you want to avoid the most. So unless you're really, and EMS, many times in our community, we know some of these families that we're dealing with. So if you know that family and have a really close relationship and you know what their religious beliefs are, I think that's fine. But in general, it's probably better to avoid religious discussions because everybody has lots of different beliefs, and your beliefs may not be exactly what someone else's beliefs are. So you could get into a bit of a confrontation sometimes unknowingly by gaining in some of these conversations. So I talked about earlier, not using phrases like passed on or passed away. You've got to use the word dead or died because everybody understands dead or died. But all these other things people may not understand. Things like we lost him, going to be with the Lord. God must have had a plan. And remember, all these things are things that have been said to family members. Expired is my favorite thing not to say. So milk expires. People don't, but we say expired all the time. So this cartoon says, I just found that, this is a doc examining this dude's scalp. He says, I just found an expiration date on your scalp. Want to know what it is or be surprised? So we don't want to say expired. So these are things that have been said in studies looking at folks and when they were dealing with folks. He's in a better place now. I know how you feel. I had it happen to me. And that's easy to do. That's really easy to do. I mean, obviously, it's by the time you reach a certain age, almost all of us have experienced death of a loved one. So it may have happened to us. And that's great. You want to draw on that experience and use it, but you don't want to make it about you, right? So that's one of the reasons they say, that phrase is better left out. He had a good life. Well, you may not know that he had a good life. At least he's not suffering. It was for the best. My favorite, this was actually said, at least you have 2 other children. Well, nobody lives forever, and that's true. You're young. I'm sure you'll find another spouse. So just some good examples of things not to say. So the other thing, one of the other things you can do that we've done this both in Stokes and Davie is to make a brochure for the family. So it can be pretty simple, but it can have a lot of information on it. And it's not something that family is going to use that day, maybe the next day, or maybe 3 days later. But usually after all the neighbors are gone and all the family's gone and all the food's been eaten and somebody's there kind of by themselves after this has happened. Now they may pick up that brochure and say, wow, these guys really were great. Not only were they great to me on scene, but they left information to help me after my husband's died. So, and there's a bunch of stuff on here, and I'll show you an example of this in just a second. But my dad died back in 2003, And I was surprised that my mom needed about 15 copies of his death certificate to close out different things. So it's amazing what you do need after somebody dies, because I went to her on a lot of these visits, and I couldn't believe how many death certificates we needed to take around to different folks. So I'm not going to go through all these. I'm going to show you. This is again, I don't know what happens when you switch this over to Microsoft, but it blurs out all the images. So anyway, this just says your agency. It gives contact numbers for the agency if folks have any other questions. And this basically says things you'll need in the next 30 days to the next year. And this is stuff you need in the first 1 to 4 weeks. So, you know, if they're a veteran, you've got Departments of Veterans Affairs, Social Security Administration, vital records, Register of Deeds, public health, hospice grief support, and we've got local stuff and one in Winston. So, you know, you can take this and tailor it to any support folks or agencies that you have here in Davidson. You know, locate important documents, will, birth certificate, social security cards, marriage license, military discharge papers, and you really do need all this information when someone dies. And then funeral home information. Most of the time, we're probably going to get that. If it's not an ME case and you're making arrangements for a funeral home, you probably already got most of that information. But again, it's just a nice resource for folks to have. So what we did is this is a trifold document, so it's a front and a back. And on the inside, it kind of says immediately after death, things that need to be done. Funeral home of choice, religious leader, alert immediate family members, contact your employer, alert the executor of your state if you have one, arrange care for dependents or animals if you've got them. So there's all sorts of good information on here. And then the next is in the next month after death. So it just gives you a nice synopsis of a lot of things that you need and things that you need to do that sometimes people don't think about for a long time after death. So again, I think this is just a really nice brochure to leave. It's got your name on it, it's got your agency, and it says, wow, I care enough about this family to leave them some information after this happened. So to kind of summarize, you know, we want to remain professional and compassionate at all times. Choose your words carefully. Make sure we don't say those things that we know are not good to say. And even though resuscitation is our first mission, the family definitely comes equally as important. And people do remember what you say. They may not remember the great intubation you did or the great EJ you placed, but they will remember what you said. So just make sure you remain professional and compassionate. Any questions at all?
There was a lot of stuff to go through.
What's your take on allowing them to join the resuscitation?
So someone wants to do CPR with them?
Family members want to join in to help out so that they feel like they did everything they possibly could.
I think that would be fine, because honestly, if they may have been doing CPR before anyway. And again, that would be a good way for them to have closure. So as long as you make sure they're doing good, effective CPR, and that's okay. They would probably take instruction better than anyone else. Push faster, not so hard, push deeper. So I think that would be perfectly fine. So here's where I draw the line with saying, yes, you could be part of the team, and sometimes you actually might need to, depending on where you are. But make sure that you're changing them out every 200 or 2 minutes. I would treat them just like anyone else, because they would even be more likely to want to be the hero and try to do tipping as a CPR. So as long as you're changing them out, I think that's fine. I think they would benefit from it psychologically later. They have much better grieving and much better support in doing that. So yeah, I've never had that question. That's a good question. So,
well, I run up there with guys, and I've had both situations. They've let them and not.
Yeah,
that's why I was asking.
Yeah. Now, I think as long as they're doing good CPR, it's perfectly fine to let them be involved. As long as you're changing them out with everyone else. Any other questions? All right. Thank you very much.
I just had a couple of quick comments. One thing about what Dr. Nelson said about painting a bleak picture up front. People's perception of CPR and survival of CPR is really heavily influenced by television. And on TV, almost everybody survives CPR. So the fact that only 8% survive CPR is shocking news to most people. So that is really important to communicate up front so that they have a realistic expectation. The other thing about giving bad news is I think it is best delivered in a stepwise approach, so that when you paint a bleak picture up front, it's not quite as shocking as at the very end to just suddenly say, well, your family member has died. That's something I do in the hospital with traumas. Giving a realistic perception of what's going on early helps people to deal with bad news better. Dr. Nelson mentioned, thanking people for doing CPR. which I agree is very important. I like to tell people that even if they didn't do, CPR, or if they did, that they did everything that they could, that they couldn't have changed the outcome. So that's something that people will specifically ask a lot of times. Could I have done anything differently? And I also like to communicate to family members that I don't think that their family member suffered. That they weren't experiencing pain during CPR. And the last comment is that one resource that you can give to people is that hospice has grief counseling and support groups for people, even if their loved one didn't die in the hospice center. They, no matter where your family member died, you can participate in the grief support groups at hospice, which are really good.
One of the nurse liaisons from Hospice at Davidson County, right down the road from you guys. Again, thank you for having me come speak just a little bit about hospice and what we do in the community. I know you guys get a lot of calls on hospice patients, but usually those calls are on our COPD patients and our CHF patients that we've had about a week, and they are used to calling 911. We try to retrain them from the first time. I actually visit patients in the families in the hospitals and help transfer them home or to the hospice house, whichever direction they're going with hospice. And just a little hospice 101, to be a hospice patient, they have to have a 6 months or less prognosis from their their primary care physician or their oncology doctor, whoever's following them and being their attendant. If we have a patient, which we see a lot of folks in the community that have never had a physician, our medical director, which actually today is her last day full-time, and we are in transition. So Dr. Arnold and Dr. Garcia from the VA are interim for us until we have another full-time director, who will be Dr. Jennifer Davis in April. She's coming from Baptist. But we do have someone available 24/7 to our patients that don't have doctors. They can be their attending if they don't have a known primary care physician in the community. Our referrals can come from anywhere. They can come from friends. They can come from family, caregivers, loved ones. They can come from a pastor. They can come from you guys. It can really happen anywhere. Once we get the referral, we contact the family and the patient and see what their wishes are, and if they want us to pursue even like an information session in the home. We do a lot of those as just education about what the team is about, what we do. Our goal is to keep them home and keep them comfortable and out of the hospital, if that is their goal. Our main pre-assessment meeting in the home is to make sure those goals match. Some of our COPD and CHF patients, it takes a long time to get them to that goal because they are so used to calling you guys. We tell them from in the hospital setting into that pre-assessment meeting and the actual admission, we become your 911. Please call our nurse on call. Let her come to you. You still have a family member that's there, Mama can't breathe, and she's turning blue, and they will call 911, even though that DNR is on the refrigerator. They don't have to have DNR to be a hospice patient. Medicare has not changed that yet. I see it coming in the future, but it is not there yet. So they do not have to be a DNR to have hospice. That is something that we work with them every week and re-educate and just re-discuss that with them gently sometimes. But some patients are very adamant. They have it in the hospital when we meet with them. They know that's what they don't want is CPR. So they will definitely let their loved ones know that's what their wishes are. We try to stress to them that living will, it's just a piece of paper. If you stop breathing in that house and an EMS is called, they're going to resuscitate you because they have to. So we try to stress that to them as we educate them and as our social workers work with them. It consists of course, the patient and their primary care physician, and then our nurse and social worker. The only two parts of the team in our team that they have to have. Other parts of the team are optional, and they can have home health aides, chaplain, and volunteer for extra support. And our main role is support and education of the dying process and helping the family have the tools that they need to manage their loved one in the home comfortably. And if they get into a panic stricken and they call 911, usually they have our contact number on the fridge, and you guys can call our nurse and they can come to the home to visit and try to help transition them to the hospice house to keep them out of the hospital. Because I know that ER doctors do not like hospice patients coming in the hospital. And we prefer them to be managed at home or the hospice house, but they have the right to go to the hospital. So some of that we have no control over, but we try to continually work with families to try to get them to, help us manage you at home, and if not, we can go towards the hospice house if we have beds. We do have a 12-bed facility. 8 of those beds are Medicare beds, or what we call general inpatient beds, which are for symptom management needs. So if we have a patient in the home and our nurse is called, that is where they try to transition them to if we can't get those symptoms managed. We do have bereavement support for the community if they did not have hospice patients, or if they were not a hospice patient. So if y'all were on like an accident or a DOA that you come in and they're dead, and family needs that support, if y'all do you have a package available to hand families? Do y'all have that? Okay. If y'all do get that resource, we could be added as a resource to hand them with our number for bereavement follow-up. We are required by Medicare with our hospice patients to follow families for a year, and that is free of charge. So if our social workers or bereavement counselors meet with them and they feel like they need more support than we can offer, they will refer them to a professional psychiatric help, or if it's deeper than what they can meet. But they can at least meet with them and talk with them and see where they are in that journey of grief. We do find that their death process, if we've been working with them months versus days to weeks, their journey in the grief process is so much easier. It is really, really hard when we get a lot of referrals in the last days. So in the community, they go to the hospice house, they kill them. That is the generalized myth of hospice expectations in the community. When they come to the hospice house, they have to be in their last days to weeks. They're dying. And they have to have a symptom need to come. So that is our goal, is aggressive symptom management at the hospice house. We only use morphine if it's needed. We only use the drugs that are needed to manage their care. Some of them never need it, but they are dying when they go in. Unfortunately, we get referrals in their last hours sometimes, and they don't last a whole day. They reach their comfort level, and then they pass on. I just wanted to kind of clarify some of our myths that are in the community, but if y'all are ever in a home of a person that you have gone to see like 3 times that month, and your COPDers called you back again, and they're wanting to go back to the hospital, or the patient's not wanting to go, but the loved one wants them to go, if they're refusing to be transported, you could talk to the family then. Have you considered hospice, as an option for your loved one? Their goal is to keep them home and keep them comfortable. I can leave you some guidelines that are required by Medicare for us to even accept a patient for heart, lung, Alzheimer's. We see a lot of Alzheimer's patients. About 50% of about 45% of our patients are cancer related. The other 55% are non-cancer diagnoses. So we have Alzheimer's, COPD, CHF, ALS, just so many different end-stage diagnoses that we work with. So I just wanted to kind of see if y'all had any questions when you're in the field, if you ran into something that I can help answer for you. I'm going to leave you some things that are just resources that we use using hospice care when a loved one is terminally ill. I'll leave you some of my cards. If you ever are in the home and they want to contact or something, feel free to give them our number to call for a resource. But thank y'all for letting me come. Y'all do great work. I've ended up on a couple of policies even in our neighborhood, and y'all are awesome. I really appreciate you. I know you don't get told that enough, but thank you. Y'all are the stress relievers on first contact when you come in those doors, and you're awesome. If you have any questions, I'll hang out and be with you here for a little bit. But